Welcome to the Cardiovascular Pulse, where we dive into medical breakthroughs, leading technology, and healthy lifestyles. Join us as we empower you on your journey to a healthier and stronger you. Hi, listeners. Joining me today is Dr. Peter Fail and Dr. Shane Prejean, interventional cardiologists at CIS in Houma, Louisiana, who specialize in treating structural heart disease. They recently celebrated a major milestone as they completed their 1,000th Transcatheter Aortic Valve Replacement, also known as TAVR, procedure used to treat aortic stenosis. Today, we will be discussing this milestone and what it means. Thank you both so much for being here with me today to discuss this milestone.
Thank you.
Thanks for having us.
Of course. Well, first off, can you tell me a little bit more about the structural heart program that we have here at CIS?
So we started this program probably about 15 years ago in the early stages of when structural heart was starting with both TAVR and with mitral valve repair. And over the years, we've been basically seeing patients specifically dying with those problems and have improved that over the years. And Shane joined us about 4 years ago after he left University of Alabama and came to join us to help us with the program. And from then on, it's exploded pretty aggressively over the past couple of years.
That's phenomenal. Can you tell me a little bit about structural heart disease, a little bit of an overview?
So the way I usually describe it, structural heart is probably everything to do with the heart that's not coronary arteries, okay? And so we deal mostly with valves, specifically aortic stenosis or mitral regurgitation, tricuspid regurgitation or tricuspid stenosis, things like that. We also do interventions on the left ventricle itself. We do other sort of devices that help us improve cardiac function. So really anything that doesn't specifically address coronary arteries, although a lot of the patients we do see have a lot of coronary artery disease also.
As today's topic of TAVR relates, can you tell me a bit more about aortic stenosis and what is it and what might cause it?
So aortic stenosis is disease of the aortic valve. So the aorta is a big blood vessel coming out of the heart, and all the blood leaving the heart has to travel through the aortic valve to get to the rest of the body. So when we say stenosis, that means a narrowing in that valve. So if you're not emptying the heart or getting enough blood flow to the rest of the body, then there's a narrowing in that valve called the aortic valve, and it can lead to symptoms of shortness of breath, fatigue, feeling faint, passing out, chest discomfort, along with other symptoms. And so when there's a disorder of that valve, we can look into options like TAVR and other means to correct that valve so that the blood can get out of the heart and make patients feel better.
Right. And so you just mentioned some good symptoms right there that people might know that they have aortic stenosis. Are there any other symptoms or things that might happen that someone might have a sign that they might have aortic stenosis?
Well, I think Shane brought it up. He said that the three major things that we see are congestive heart failure, which would be shortness of breath, what somebody would say fluid around their heart, if you will. The other one would be angina, where they have chest discomfort. And the third one would be syncope, where they pass out. There is a fourth one that's called sudden cardiac death, which fortunately is very rare, but does occur, where people, the very first sign they have aortic stenosis, where they basically pass. That tends to be very, very uncommon, but we do see it on occasion on patients when, specifically in autopsy, that they had severe aortic stenosis and didn't know that they had a problem.
Right, and I would add that some people have no symptoms. So on physical exam, they may have heard another doctor, healthcare provider tell them that they have a heart murmur. So there's a lot of people, have a lot of thoughts about what a murmur is, but it's just a sound that we hear when we listen to someone's heart. And very commonly, that sound or that heart murmur is an indication that they have some sort of structural heart disease. And particularly in older patients, the most common disorder causing a murmur in patients is aortic stenosis. But many people come in and they've told me that they've had a heart murmur their whole life, or many years, and when they've heard it several times, it sounds benign or nothing that they need to worry about. But things can progress and get worse, and things could be severe, and you don't know about it. So I would encourage the audience, if they've had a long-standing heart murmur, that they see a heart specialist and make sure to get that checked, because sometimes people have no symptoms
Right.
before they have a major heart problem, and we want to know about those patients early so we can get them the care that they need and get treated before something bad happens.
Absolutely. I think that's very important. When should someone generally come in to get checked for aortic stenosis? They might think whether they don't have symptoms, whether they do have symptoms, when should they come in and get checked for a screening?
Definitely if you've heard someone say that you had the heart murmur, like I said, but if you've had any of the symptoms we've mentioned, particularly if you have a family history. So aortic valve disease has different causes. So when you have aortic stenosis, it may just be simply what we call calcific aortic stenosis, calcium buildup over time, and that's typically part of aging, and it tends to occur in the older population. However, there are some congenital conditions that cause an abnormality in the aortic valve when you're younger. So if you have something that runs in the family, some sort of family history of heart disease, particularly valve disease, we'd love to see those patients early, because we'd like to prevent it from getting worse if we can, or to monitor it to see if it's getting worse. People with prior radiation therapy to the chest can cause valvular heart disease. Prior infections in the heart valve, various causes can affect the heart valves, and if you've had any of those conditions, it's good to come get checked, and particularly if you see your primary care or somebody else and they're concerned about something with your heart, we're always happy to see those patients.
Most definitely. Is there any way that this can be prevented, or is it something maybe you're born with?
Go ahead.
We tend to see that some of the calcific valve disease runs in a constellation with other types of vascular disease. So it is important for everybody to avoid cardiovascular risk factors, which is a healthy diet, regular exercise, controlling things like blood pressure, cholesterol, diabetes if you have those, and following those preventative measures, because I do think that we see a higher rate of valvular disease in people with other risk factors for heart disease and other types of heart disease. I want to talk about LP a little.
LP little a, yeah. So there is a test we can do. So LP little a, I always say it's sort of like a hitchhiker, if you will, on the bad cholesterol molecule. And what's interesting about that is in a lot of patients with aortic stenosis, they have a very elevated LP little a. There are obviously a lot of patients who have aortic stenosis that don't have that, but what's interesting, that in years to come, that may be a very interesting target for us to look at in treating those patients early who have elevated LP little a, and maybe we can forego the issues of aortic stenosis in their lifetime. As we talked previously, that sometimes becomes a little bit difficult just on a timing. If you have somebody who's 30 years old and has an elevated LP little a and you start treating them now, you may not see anything for another 50 years. And so it becomes very difficult to follow those patients out longitudinally, but it would be an interesting target.
And particularly now, we've checked LP little a's in patients for years, knowing that it increases the risk of aortic stenosis, but also other types of vascular disease. But now there are clinical trials ongoing to actually lower LP little a to see if it can help prevent heart disease in the future for those patients. So it's actually something we can know about now and actually act upon in the near future once those therapies become available. So we're excited as a cardiology community to potentially have a therapy to lower that in the future for those patients. It's still in the clinical trial stage, but I do think it'll become mainstream in the next 5 to 10 years.
I believe so, yeah.
Absolutely. These are all great advancements in structural heart care, and kind of like this milestone that we have today that we're discussing with the 000th TAVR procedure, all of these advancements in preventative care, things we can look forward to in the future, that can just really help tremendously in the quality of life of people. And I guess going from there, can we discuss the TAVR procedure in a little more? Can you tell me what it is and how it benefits patients?
So TAVR is Transaortic Valve Replacement. Some people call it TAVI, where it's a valve intervention. But either way, we're basically replacing or repairing the valve, if you will. So we're putting a brand new valve in the valve that's stenotic. Basically, the vast majority of these people, we do it through the groin. We have a valve that is basically loaded onto a catheter. That catheter then goes into the area of the aortic valve itself, and then we actually can open that valve up. And basically what we do is we push the native valve out of the way, up to the side, and this stent valve, if you will, becomes the brand new valve for the patient. It takes us about an hour to do most cases. Some are a little bit longer, some are a little bit shorter. But over the years, as we've been doing this, we've been able to get much more accustomed to doing the procedures. The procedures have become much more easier. I don't know, easier is the right word, but I think the staff that we have is well trained in what we do, and we're able to make these things happen. When I first started doing TAVR, it was we did 2 in a day because it took all morning to do the first one and all afternoon to the second one. And now Shane and I are doing 4 and 5 in a day, typically being able to go through. And I think a lot of that has to do with development of the devices themselves, development of the techniques themselves, the comfort level of the staff, anesthesia, the surgeons, et cetera. I think as a community itself, we've been able to actually advance this process much faster and able to provide it to more patients.
Definitely. And just how you said, how it's evolved over the years, and now it's minimally invasive. And recovery time, how does that look for patients too?
Yeah, so like Pete said, we typically, the procedure itself takes about an hour. If everything goes well with the procedure, the patient can expect to stay 1 night in the hospital at a maximum, typically. Previously, just like every therapy that comes out, we were expecting patients when this started to, stay in the hospital for a week or so, and similar to the prior approach, which was surgical valve replacement, cardiologists weren't sure what was going to happen after we put these valves in. But as we've gained that experience over the last 10 to 15 years, things have become less invasive, and the techniques have been refined. So it's led to shorter lengths of stay in the hospital. Patients have had a better experience. They're up and walking within about 4 hours of the procedure. We use less sedation during the procedure so that you can wake up quicker. Really it's a period of observation overnight to make sure nothing new occurs after the procedure, but patients are getting back to their level of function quicker, and really it's dramatic to see how patients do well and are able to get back to their normal life very quickly.
Absolutely, very quickly. And are there other treatment options for aortic stenosis other than the procedures too? Is it so?
No, well,
I would say we as cardiologists are very we're always looking for newer and less invasive treatments, and TAVR is a great option for many patients. There's still a role for surgical valve replacement. So in those who are low risk and younger, not each single valve that we put in may not last forever. So we, as a heart team, will see each patient when they first come in and decide on what might be the best option for patients for their lifetime. So as medicine has evolved, we've tried to get more of an individualized approach for each patient. So there are times where younger, lower risk patients do need actually traditional open heart surgery and a surgical valve replacement. So when a patient comes to CIS, they get evaluated by a structural heart specialist like Dr. Fail or myself, and they also get evaluated by a heart surgeon, and we work as a team in a collaborative approach to decide what treatment might be the best. So it may be that you're basically very young and healthy, and you might, for your lifetime approach to valve disease, you might do better with surgery. And we want to pick the option in which people do better and live longer. So that might be the approach. Or we might find that you're an ideal candidate for TAVR, in which we can do it in a less invasive way. And that may be the approach. But every patient gets an individualized discussion by the heart team, so we can decide on the best treatment.
Absolutely. I love what you said. Individualized, personalized care right when they walk in. and tailored to each person's needs. So who might be a good candidate for the TAVR procedures?
Well, obviously, aortic stenosis, right? And we look at, so I think as Shane had said, a younger person, 50 years old, for instance, each one of these valves that we put in do have a finite lifespan, and they won't last forever. And so therefore, a 50-year-old, if we did a TAVR on them, may need 2, 3, 4 procedures. And that becomes really problematic after the second or third procedure, because you're basically putting like the Russian doll. You keep putting more valves, so you can't do that. So that person really would benefit from doing surgery, may benefit from doing a mechanical valve where they don't have any worry about the lifespan of the valve itself. An older individual, say 80 years old, where surgery may be a little bit rough, you want to say maybe TAVR. If they meet all the requirements, their access looks good, from going from the groin to the heart is okay. They don't bring a lot, and I'm not going to say a lot of comorbidities, because most of them do bring a lot of comorbidities to the table. But basically, we would talk, as Shane said, we talk amongst ourselves between the heart surgeons and the team and say, what do we think is the best approach for this patient? The vast majority of them actually will be a good candidate for TAVR. How we get there sometimes is a little bit different, though.
Absolutely. And we've been talking about the procedure and the milestone in that way, but what does this mean for you guys and for your patients? How do you feel about this?
Well, obviously we're excited because that's what we do every day. It's I think from 1,000 cases, that's a really achievement for TAVR. It's a small community, and it shows the dedication of the team, the staff, and then the physicians that refer to us. Shows that they're confident that we're able to provide a good product for them and their patients, and that's reassuring.
Yeah, I think it's been an evolution. CIS is always one of the pillars of our organization has been research. So currently, TAVR is not a research area because it's well established, as evidenced by the 1,000th case that we recently did. But it all started somewhere. So CIS has always been on the forefront of technology and research. So it began when Dr. Fail really started the program. And at that time, it was investigational in the fact that this was a new way to replace the aortic valve. So the only option previously was open heart surgery and surgical valve replacement. But we knew a lot of people in that era weren't being treated because they were too high risk for surgery. And the 1,000th case is kind of like a testament to the evolution of this procedure and the technology, and the fact that we started with those that had no other option and they were very high risk for anything. We're able to demonstrate a benefit in those patients through clinical trials, and then this is spread even to lower risk patients, in the fact that the technology has gotten better. Our team has the experience that has built up over these years, and we can now offer this therapy to a wide range of patients due to the work done over the last decade or so. And the 1,000th case is really a testament to all that hard work and dedication and the evolution of this technology.
So whether I'm coming from down the bayou, the region, the state, what does this program set apart in structural heart care?
I would emphasize that through our commitment to technology, CIS has been able to bring technologies such as TAVR or other structural heart procedures to the patient. So we see people who don't really want to go to a major city or can't go to a major city for various reasons, but CIS has been able to bring that technology to the communities of South Louisiana so that we can offer TAVR in a very experienced center with a very experienced team, as evidenced by our 1,000th TAVR case, that you don't have to travel far. So we take pride in that, and we're really able to connect with the patients because we live in these communities, and the patients enjoy staying close to home where they can get advanced care close to home.
Right, innovative care right here close to home.
Right. And then we have other TAVR centers, CIS, as one in Lafayette, as well as Baton Rouge. So we've been able to expand this technology into other centers in Lafayette, in the CIS network itself. So patients don't have to drive even further.
Is there anything else that people should know in general about structural heart disease, aortic stenosis, about TAVR as a whole?
Well, I think what's interesting about structural heart disease is if you go back even 20 years ago and said this is what we were going to be doing with patients, everybody would have said that's not possible. And so the advent of all of these techniques, whether it was a mitral valve, whether it's the aortic valve, whether it's a tricuspid valve, have shown an evolution. And I think there are a lot of people that are currently doing a lot of thinking sort of outside the box that are helping patients who had no other options in the past. Surgical options were difficult or very high risk, and now we're starting to see more and more ideas. I think a lot of that has been piggybacked on the explosiveness, if you will, if that's the right word, in TAVR. And TAVR has become such a commodity now that where you can see it literally in even smaller communities than Houma, Lafayette, or Baton Rouge, where mitral valves and tricuspid valves are becoming more and more prevalent. We're starting to understand more other diseases that I think we can now address based on a structural heart program itself.
Thank you both so much for sharing your insights with me today and celebrating this milestone of the 1000th TAVR procedure. Thank you both for being here.
Thank you.
Thanks for having us.
We hope that this has empowered you on your health journey. If you have health concerns, visit cardio.com to learn more or request an appointment. Make sure to follow this podcast as well as CIS on social media for updates. Thanks for listening.